Echocardiography was one of the first modalities of point-of-care ultrasound. We used it to rule out pericardial effusion and tamponade. Currently, in emergency medicine training, it is standard to learn how to rule out pericardial effusions, as well as to estimate ejection fraction and to rule out right heart strain. Now, echocardiography can be quite complex. There is much anatomy to review, there are many pathological states, and there are many views that you can utilize in this exam. To start, we're going to go over some basic anatomy, and we'll go over just 5 cardinal views of echocardiography. Now, it's important to note that you can do this exam. It's been shown that trained emergency physicians, as well as residents and junior residents, can be trained to rule out pericardial effusions, as well as to estimate ejection fraction. The first cardinal view is the parasternal long axis. You place the probe on the left sternal border of the patient, 3rd or 4th or 4th or 5th intercostal space, and you're going to point the indicator either to the patient's left hip or the right shoulder, depending on the convention of the place you work. At my shop, it's towards the left hip, and that's what the indicator, or the arrow, indicates in this situation. And in this real video, try to appreciate the same anatomy that's on the adjacent still image. You should see the right ventricle at the very top or most superficial part of the screen, followed by the interventricular septum, followed by the left ventricular outflow tract and the aortic valve, and then the mitral valve you can see flapping up and down, and as well as the left ventricle and the left atrium. The bright line at the very bottom of the image is the pericardium. By keeping your probe in exactly the same location, except turning it 90 degrees, now with the indicator pointing towards the patient's right hip, you get the parasternal short axis view. You can see many things in this view. If you look at the middle part of the short axis, you'll typically see the mitral valve, which we like to call the fish mouth view because it's a 2-valve system with the anterior and posterior leaflets that looks like a fish mouth as it flaps open and closed. If you were to point the ultrasound towards the apex of the heart, which is closer towards the patient's left hip or left chest, you will get more of a papillary muscle view, and if you keep going, you'll see the very apex of the heart as well. If you point the ultrasound up towards the root of the heart, you will see more of the aortic valve, as well as possibly the tricuspid valve and pulmonic valves, and you can get a nice sense of how all these valves are working. In this video, the aortic valve is centered in the middle of the image. It is sometimes referred to as the Mercedes-Benz sign because it's a 3-leaflet valve system. The left atrium is on the bottom part of the screen, or posterior to the aortic valve. The right atrium is just left, and the tricuspid valve is just left of the aortic valve as well. And the right ventricular outflow tract is at the top of the screen. Keeping the indicator pointing towards the patient's left hip, you're going to trace the apex of the heart, lateral in the chest, and when you're usually around the region of the nipple, you can point up with the transducer towards the root of the heart, which will give you an apical 4-chamber view. This view is perfect for viewing all 4 chambers of the heart, including the right ventricle, right atrium, and left atrium, as well as the tricuspid and mitral valves. Identifying the moderator band is a telltale sign that you've identified the right ventricle correctly. This view is ideal for comparing chamber sizes, and if you point the ultrasound beam just anterior, you can evaluate the mitral valve, tricuspid valve, as well as the aortic valve in the 5-chamber view. The subxiphoid view is shot just below the subxiphoid process with the indicator pointing towards the patient's right. You have to push pretty hard and get right underneath the bone and point the ultrasound beam very anterior in the chest. This should give you a 4-chamber view with some liver just anterior in the screen, and you can see the right ventricle, septum, left ventricle, right atrium, and left atrium, as well as often the descending aorta. The final view I have to mention is the long axis of the IVC, or inferior vena cava. In a future episode, we'll talk about exactly what the IVC can do for us in our echocardiography, as well as other types of examinations. But just know that a very large IVC that is non-distensible, that is non-plethoric, and does not vary with inspiration and expiration is likely consistent with some sort of obstructive shock or fluid overload state, whereas a very collapsible IVC would be more consistent with dehydration, some sort of hypovolemia. Now I know that the anatomy and orientation can be confusing when watching a video like this, so now let's watch a real exam and review exactly how to do this. Like other exams, we're going to stand to the right of the patient. We're going to put our ultrasound machine to the right of the patient as well. You're going to choose your transducer, which is the cardiac transducer or the phased array probe. Choose your exam type, which is the cardiac exam type. Use some ultrasound gel, and we're going to start with the parasternal long axis. Placing the probe just left of the sternal border in the 4th and 5th intercostal space, we're going to try to shoot in between the ribs and point the indicator towards the patient's left hip. By doing this, we're going to get a long axis view of the heart. Notice in the view the apex is at the left of the screen, whereas the root of the heart is on the right of the screen. The most interior portion is the right ventricular free wall, followed by the right ventricle, the interventricular septum, and then the left ventricle. You can see a nice view of the aortic valve and mitral valve and the aortic outflow tract, as well as the pericardium, which is the bright line below. This is often the ideal view for evaluating ejection fraction. The next view is the parasternal short axis. We just rotate the probe 90 degrees, and now the indicator is pointing towards the patient's right hip. And what we see is a circumferential view of the left ventricle. This is a great view to look at the contractility of the left ventricle, make sure there's no obvious wall motion abnormalities. You can see the mitral valve, the fish mouth view in the middle, and if we go towards the root of the heart, you can see more of a aortic valve view. Pointing the ultrasound beam more lateral left chest or more towards the apex of the heart, you get a nice papillary muscle view or apex view. Moving on, we'll trace the apex of the heart over to the left lateral chest, just below the nipple, and we will have our apical 4-chamber view. Having the patient lay on his left side can really help you here. In this view, you'll have all 4 chambers of the heart, including the right ventricle, right atrium, and left atrium. You will also see nice views of the tricuspid valve and the mitral valve. In this view, we can assess for wall motion abnormalities as well as compare chambers of the heart. Typically, the right ventricle is no more than 2/3 the size of the left ventricle. If it is more than this, then that could be associated with acute right heart strain or possibly chronic right heart strain, and this is clinically important. And now that the beam of the ultrasound is parallel with blood flow, this is the ideal view to evaluate mitral, tricuspid, and aortic valve regurgitation. We will now transition to the subxiphoid view. In this view, you place the probe just inferior to the subxiphoid process in the patient. The indicator is pointing towards the patient's right side. You place your hand on the top of the probe because you have to point the ultrasound beam very anterior in the chest because that's where the heart lies. In this view, you'll see a liver at the top of the screen, which is anterior in the patient. And just below that, you'll get a nice 4-chamber view of the heart. Most anterior is the right ventricle, followed by the left ventricle, and then the right atrium is also anterior, followed by the left atrium. You should also appreciate the mitral valve and the tricuspid valve in this view. Now turn the probe 90 degrees with the indicator pointing towards the patient's head and facing the ultrasound beam more posterior in the patient, that's more towards the bed or the patient's back, and you get this long axis of the inferior vena cava. Now the IVC sits just to the right in the patient's body, and if you point the ultrasound beam to the left, you will visualize the abdominal aorta. The abdominal aorta has a thick wall which looks bright white on the screen, and it sits right on top of the vertebral bodies, which are also bright. The IVC can be distinguished because it's got thin walls and it dumps right into the right atrium, and it also has the hepatic vein dumping into the IVC. Remember, the IVC is important because a very large IVC may be consistent with fluid overload or obstructive shock, whereas a very collapsible IVC would be not consistent with those diagnoses and more consistent with hypovolemia. Now, I hope you've enjoyed this video and learned something about cardiac anatomy. In future episodes, we will discuss pathology as well as some more anatomy and techniques in detail. Now it's time to practice this in person, so scan on and please keep posted for future episodes.